Glaucoma drainage implants in midlife, decoding the long-term success rates. Glaucoma drainage implants, also called aqueous shunts or tube shunts, are filters placed in the eye to lower pressure by draining excess fluid. They are often used when standard surgery, trabeculectomy, is unlikely to succeed or has already failed. Common devices include the Ahmed Glaucoma Valve, a valved implant, the Baerveldt Glaucoma Implant, a larger non-valved plate, and the older Molteno implant. Newer, minimally invasive options like the stent or PreserFlo micro-shunt exist, but they are generally for milder cases and have less long-term data. Trabeculectomy is the classic glaucoma surgery that creates a new drain in the eye without a device. A thin flap is made and often treated with an agent, mitomycin C, to prevent scarring. By contrast, a tube implant has an artificial tube leading to a small reservoir, plate, under the eye's surface. In effect, both aim to create a bleb, a drainage pocket, but trabeculectomy relies on the body's tissues alone, whereas a tube shunt uses foreign material. Each approach has pros and cons. Tubes usually are chosen when trabeculectomy may fail, for example, if the conjunctiva is scarred or in some secondary glaucomas. Studies often compare tube shunts versus trabeculectomy head-to-head because both lower pressure, but with different mechanisms and healing tendencies. Defining success and failure. How do researchers judge success after glaucoma surgery? There is no single definition, so results can look different across studies. In general, complete success means the eye pressure is controlled without any glaucoma medications and remains in a safe range. For example, 1 or 21 mm/Hg, often with at least a 20% drop from baseline. We measure pressure with IOP, intraocular pressure. The exact target varies. Some studies use 18 mm/Hg, some to 21 mm/Hg, for instance. Common practice is to say IOP in the mid-teens or below is a success if it's stable. Qualified success allows glaucoma medicines. In this case, the IOP is still in the target range, but the patient is using eye drops or pills in addition to the surgery. Failure is defined when the pressure is too high, above the chosen cutoff, or not lowered enough, less than the required percentage drop, or if another glaucoma procedure becomes necessary. Some definitions also count vision loss, e.g. loss of light perception, or serious complications, like uncontrollable hypotony, as failure. In short, failure generally means the surgery did not solve the problem on its own. Because different researchers pick different pressure goals, success rates can't be compared directly unless the definitions match. For example, some trials counted any IOP up to 21 mm/Hg as success, while others needed touch 18 mm/Hg. It is important to note whether a reported success rate was complete, no meds, or qualified, with meds. Many papers report both when data is available. Long-term outcomes. What do the numbers show? Tube shunts versus trabeculectomy, TVT study. The landmark Tube versus Trabeculectomy, TVT, study was a randomized trial that followed patients for 5 years. It compared the Baerveldt tube 350 mm plate to trabeculectomy with mitomycin. Key findings at 5 years, 212 eyes, were pressure control. Both groups had similar final IOP around mid-teens and a similar drop in medication use. Success, no failure rate, 70.2% in the tube group versus 53.1% in the trabeculectomy group at 5 years. In other words, failure, meeting failure criteria, had occurred in 29.8% of tubes and 46.9% of trab outcomes, p equals 0.002, showing tubes held pressure more reliably over time. Reoperation. Additional glaucoma surgery was needed much less often in the tube group, 9% versus 29% in the trabeculectomy group at 5 years. These results suggest that after 5 years, a tube shunt was more likely to maintain target pressure than trabeculectomy in this study, for eyes that had prior cataract or trab surgery history. The IOP reduction achieved by both surgeries was similar, but trabeculectomy more often required repeat surgery. Even at 3 years of follow-up, the study showed cumulative failure rates of 15.1% for tubes versus 30.7% for trabeculectomy, i.e., 84.9% versus 69.3% success at 3 years. In practical terms, the TVT study implies that about 30 to 40% of tube shunts may fail or need reoperation within 5 years, whereas trabeculectomy failure was around 47% in that time frame. Note, failure here includes not only high pressure but also tube removal, vision loss, or need for more surgery. The pattern seen was about a 5% failure per year for tubes. So roughly half survive at 10 years, see below. Ahmed Valve versus Baerveldt Implant, AVB and ABC studies. Several trials have directly compared the Ahmed Valve, Ahmed FP7, to the Baerveldt Implant, BGI. Both designs are common, and understanding their long-term outcomes is important. Briefly, Ahmed FP7 has a built-in valve that resists very low pressure, so-called flow-restricting valve. It often lowers IOP quickly, but may allow higher long-term pressures. Baerveldt non-valved relies on a temporary ligature until tissue capsule forms. It can achieve lower pressures but sometimes carries a small risk of low-pressure complications, hypotony, once the ligature dissolves. Key study findings at 3 and 5 years, several hundred eyes combined. 3-year outcomes, the AVB, Ahmed versus Baerveldt. Study reported that at 3 years, the cumulative failure rate was 51% with Ahmed versus 34% with Baerveldt, p.03. Mean IOP was slightly lower in Baerveldt eyes, 14.4 mm/grams, than Ahmed, 15.7 mm/grams, and Baerveldt eyes needed fewer medications, 1.1.8 p=0.002. Complication rates were similar, though hypotony-related issues were more common with Baerveldt. 5-year outcomes, ADB study. In a later 5-year report, the AVB trial showed 5-year failure of 53% with Ahmed and 40% with Baerveldt, significantly favoring Baerveldt, p=0.04. The average IOP at 5 years was 16.6 mm/gram versus 13.6 mm/grams Baerveldt, and final medication use was 1.8 versus 1.2 drops. Hypotony failures were 0% in Ahmed versus 4% in Baerveldt, since only the non-valved can overdrain. 5-year outcomes ABC study. The ABC Baerveldt comparison study, a different multi-center trial, found a 5-year failure rate of 44.7%, Ahmed versus 39.4% Baerveldt, not statistically different, p=0.65. At 5 years, the IOP was 14.7 mm/grams Ahmed versus 12.7 mm Baerveldt, with about 2.2 versus 1.8 medications. Putting it together, most trials show moderately better control with the Baerveldt implant. Roughly half of Ahmed valves and about 40% of Baerveldt implants may fail by 5 years, meaning about half are still successful at that point. The differences aren't enormous, but generally Baerveldt tends to reach lower pressures and needs slightly fewer pills at the cost of a little more risk of very low pressure. Overall success rates, complete or qualified at 5 years, are on the order of 45 to 60%, depending on the study and definition. For example, if failure is 40%, success is 60%. Other implants. The Molteno implant is an older design, non-valved. Long-term data is sparser, but historical series suggest intermediate success rates, roughly similar ballpark as Baerveldt. Since its design is similar to Baerveldt, just smaller plate per stage, we treat it similarly, but it is not commonly used today. Newer, minimally invasive implants, e.g., XN gel stent, PreserFlo micro-shunt, are smaller tubes placed via ab interno approach. These have been marketed in the last decade but have less long-term evidence. Early results indicate they can lower IOP, but often not as much as traditional tubes, and they may still fail over time. For our purposes focused on long-term outcomes, the traditional Ahmed and Baerveldt implants provide the bulk of data. Age and device survival, middle age versus older patients. Age can influence healing. Younger eyes tend to heal more vigorously and scar more, which can cause drainage surgery to fail sooner. Indeed, analyses from large trials confirm younger age is a risk factor for failure of tube shunts. In a pooled study of hundreds of patients from major trials, TVT, AVB, ABC, each 10-year decrease in age raised failure risk by about 19%. In simpler terms, for example, a 50-year-old tended to have better success than a 40-year-old with the same surgery. This mirrors findings in trabeculectomy. Younger patients generally scar faster, undermining the bleb. However, most published trials have mean ages in the 60s or higher. There is very little data specifically on 35 to 55-year-olds. We extrapolate from the broader studies. Overall, middle-aged adults, e.g. 40-year-olds, may be somewhat more prone to failure than the typical study participant, who might be retired and in their 70s. But the exact drop in success isn't sorted out in age subgroups in the literature. Clinically, surgeons worry that a 40-year-old's robust healing will encapsulate the plate sooner, so we tend to expect somewhat lower long-term success in midlife than in an older person. No landmark trial explicitly reports a 40-year-old subgroup, so we rely on risk factor analyses rather than head-to-head age comparisons. In summary, younger patients, including those in their 40s, generally have a higher rate of scarring and failure after any glaucoma surgery. This is cited in the literature, but the decline in success with midlife age is a bit hard to quantify precisely. We certainly advise they will likely require more follow-up and possible additional surgeries over time. Glaucoma type also matters. Not all glaucomas are equally likely to respond to drainage surgeries. Most major trials mix various types or focus on open-angle glaucoma, but many eyes had other causes. In general, primary open-angle glaucoma, POEC, the most common adult glaucoma, tends to do decently with tubes. These patients are usually the subjects of trials, and success rates above apply. Neovascular glaucoma, NVG, from diabetes or ischemic eye disease is the toughest. NVG eyes form scar tissue very aggressively. In pooled analyses, neovascular glaucoma was a significant risk factor for failure, hazard ratio 1.8. In practice, success with NVG is often much lower than typical. Many devices fail early. Uveitic glaucoma from eye inflammation is also a high-risk situation. Studies, including meta-analyses, show that drainage implants do work, but outcomes are generally worse than POAG. For example, one review found pressure reductions were similar between uveitic and non-uveitic eyes, but uveitic eyes often needed more interventions for complications, like inflammation-related issues. We lack a clean percentage, but surgeons know these eyes scar readily and require close monitoring. Pigmentary pseudoexfoliation, traumatic juvenile, data is thinner. Pigmentary and pseudoexfoliation, secondary open angle, likely behaves somewhat like POIG, maybe slightly higher scarring risk. Traumatic glaucoma could be very variable, depends on angle injury. Congenital or juvenile glaucomas carried into adulthood are rare. They are known to scar profusely. Since most studies combine all types, precise success rates by subtype are not well quantified. We can say secondary glaucomas, uveitic, neovascular, tend to do worse. Indeed, in the pooled risk analysis, conditions like neovascular and high pre-op pressure predicted lower success. In contrast, classic POEG in an older adult had among the best outcomes. An important takeaway for a 40-year-old, the underlying glaucoma cause matters at least as much as age. Complications and need for more surgery. A vital part of any glaucoma surgery discussion, what problems can occur and how often might further operations be needed. Drainage devices have unique long-term complications. Key points. Corneal damage. Most concerning is the risk of losing corneal clarity. Over time, the tube can touch or be close to the inner cornea, causing cell loss. Studies show significant endothelial cell loss with GDDs. One study found an average 8% loss of central cells at 6 months and 12.6% at 12 months after Ahmed valve surgery. Over years, this can lead to corneal decompensation, persistent corneal swelling. One long-term series, mostly Ahmed FP7, reported corneal decompensation in 19% of eyes during follow-up. In other words, roughly 1 in 5 eyes eventually developed corneal failure requiring a transplant. In the same series, 5 eyes actually lost sight from complications. Patients should be told, a tube might control pressure but could risk the clear window of the eye decades later. Tube or plate exposure. The conjunctival cover over the device can erode. One study found about 5.8% of shunts eventually became exposed through the eyelid's lining. This is dangerous because exposure often leads to infection. In fact, tube exposure is the #1 risk factor for endophthalmitis, infection inside the eye. Infection rates reported after GDD range from 0.8% to around 6%, averaging about 2%. In short, roughly 2 to 6% of eyes may get a serious infection years after a drainage implant, almost always related to exposure. Many times, these exposures occur around 1 to 3 years after surgery, but can be as late as 5 to 10 years. Diplopia, double vision. When a large plate is sutured under the eye muscles, it can slightly alter eye alignment or movement. Double vision is an under-discussed but real problem. In one series, about 31% of patients with a Baerveldt 350 implant, the larger 350 mm² plate, reported new diplopia attributable to the surgery, compared to 13% with Ahmed FP7, smaller plate. Another prospective study, TVT-ABC combined data, found diplopia in about 3 to 5% of cases, but that likely underestimates it due to incomplete testing. The takeaway: diplopia is not rare, especially with bigger devices or multiple tubes. Patients often do adapt or it can be managed, but it's an important counseling point. Hypotony, very low pressure. Overdrainage can lead to low IOP, which can damage the eye, choroidal detachments, vision loss. Valved implants might rarely cause true hypotony. Non-valved ones, Baerveldt Molteno, have a small but real risk of late hypotony once the ligature dissolves. In the AVB study, 4% of Baerveldt eyes failed due to hypotony versus 0% of Ahmed eyes. In a clinical series, about 4.5% of eyes had chronic hypotony post-GDD. Other issues. Many eyes develop encapsulated blebs around the plate. In one report, 24.5% were noted to have a thick capsule restricting flow. Tube obstruction by iris, blood, or debris occurs rarely, a few percent. Retinal detachments or severe vision loss, phthisis, are uncommon, 3 to 4% each in one series. Additional surgeries. Probably the single biggest concern for a younger patient: how many surgeries will I need? All the above complications and gradual failure mean that multiple surgeries are common over a lifetime. For example, the TVT study, Tube vs. Trab, reported reoperation for glaucoma in 9% of tube eyes within 5 years. In the Ahmed vs. Baerveldt trials, 11 to 18% had another glaucoma surgery by 5 years. In one retrospective series of 110 GDD eyes, mostly Ahmed FP7, the average number of additional glaucoma procedures was 1.5, ranged 0 to 6 over the follow-up. In that report, 27 of 110 eyes, 24.5%, needed bleb needling or 5FU injections to reopen flow. 16 eyes, 5% needed tube reshaping or shortening. 12 eyes, 10.9%, eventually got a second GDD, and 17 eyes, 15.4%, underwent cyclophotocoagulation, laser ciliary body destruction. Some even required cataract surgery or retinal surgeries. In total, 56% of eyes had at least one complication, and many required additional surgeries. In plain language, expect the unexpected. Even if the shunt initially controls pressure, there is a significant chance, perhaps 20 to 50% over many years, it will fail or cause trouble, requiring another intervention. Patients and doctors should plan for long-term management, not a one-time cure, especially for younger patients with decades ahead. The long view, a 40-year-old versus an elderly patient. Why does age change the calculus? Simply put, a 75-year-old patient might need good control for 5 to 10 years more, whereas a 40-year-old may need 30 to 40 more years of glaucoma management. Even a 5% per year failure rate adds up. At 5% per year, about 50% of shunts fail by 10 years. In one 10-year series, roughly one half of tube surgeries were still successful at 10 years, meaning the other half had failed or needed retreatment. This implies a 40-year-old is very likely to outlive a single implant. Realistically, such a patient may go through multiple procedures over time, maybe a new shunt or other surgery every decade or so, depending on results. Each surgery carries its own risks and burns through the limited surgical lifetime of the eye's tissues. By contrast, an 80-year-old might get by with one shunt and live the rest of life with it. In practice, when counseling a 40-something patient, doctors stress that tubing is often one step in a lifetime of glaucoma care. It is usually not permanent. We might say, this implant has a roughly 50% chance to keep working at 10 years, so you may well need another surgery later, but all surgeries we have combined are aimed at preserving vision for decades. In summary, the take-home is, younger patients face a different risk profile. The same implant that works well for 5 years in a 70-year-old has to keep working for 30 to 40 years in a 40-year-old. No published data guarantees any one shunt will last that long. We rely on averages from older populations. Thus, a 40-year-old and their surgeon should plan on close follow-up and have backup plans, other surgeries, lasers, medications for the future. Conclusion. Drainage implants, Ahmed, Baerveldt, etc., are effective ways to lower eye pressure long-term, and they often outperform trabeculectomy in maintaining pressure over 5 years. On average, about 50 to 60% of shunts remain successful at 5 years, but that falls to roughly 50% by 10 years. Success is defined by reaching a target IOP, often 18 to 21 milligrams with or without medications. Age matters. Younger midlife eyes tend to scar more, and studies confirm younger patients have higher failure rates. Therefore, a patient around 40 should expect a somewhat lower long-term survival of a single shunt than an older patient. Glaucoma subtype also matters. Secondary glaucomas like neovascular or uveitic generally do more poorly, whereas primary open-angle glaucoma is most studied and fares better on average. All surgery carries risks. The notable complications of tube implants include corneal damage, with 10 to 20% of eyes affected over time, device erosion, 5% chance, leading to infection towards a 2% risk, double vision, seen in up to 30% with large plates, and overdrainage on the order of a few percent. In one study, more than half the patients had some adverse event, and the average eye needed over one extra glaucoma surgery in the years that followed. The bottom line: a glaucoma shunt can buy many years of vision by lowering eye pressure, but it is rarely a set-it-and-forget-it solution in a 40-year-old. Patients should be prepared for a lifelong management plan. A single shunt is usually one step in a sequence of therapies. The data we have, in large part from older patients, show robust midterm success, but also make it clear that failure accumulates over time. Currently, there are no large studies focused exclusively on middle-aged patients to give a precise number just for 35 to 55 years, so we apply what we know from broader studies and clinical experience. For now, we tell midlife patients that tube shunts work well initially, but can fail over decades. A young adult will likely need additional interventions eventually. We encourage them to stay engaged with their eye care, watch for signs of pressure rise or complications, and maintain a plan to preserve vision over the very long term. References: major findings above are supported by clinical trials and reviews, among others. Where possible, we cite large multicenter studies, e.g. TVT, AVB, ABC, and systematic analyses to ensure the data is reliable. Any single center or smaller reports are noted only if they provide unique insights. Tags: glaucoma surgery, glaucoma drainage device, tube shunt outcomes, Ahmed Valve versus Baerveldt, long-term glaucoma treatment, middle-aged glaucoma patients, trabeculectomy comparison, device complications. All links to sources are available in the text version of this article. You can find the full article at visualfieldtest.com. Thanks for listening. To check your visual field, click the link at the bottom of this article or visit visualfieldtest.com.